Welcome everybody to session 6 of the Pediatric Readiness Recognition Programs Collaborative, otherwise known as PRRPC. If you'll go to the next slide, just our funding acknowledgement. The Pediatric Pandemic Network, or PPN, and the EMSC Innovation and Improvement Center are supported in part by the Health Resources and Services Administration. And the contents of this session are those of the authors and do not necessarily represent the official views of, nor an endorsement by, HRSA, HHS, or the U.S. government. Next slide. So thank you again for joining us. I know we've been doing this since September and we love the attendance that we're getting. So thank you very much. The session is being recorded. If you would like to come off mute or raise your hand, you can also use the chat function at the bottom of your screen. So as usual, this is a very interactive session and we love hearing from you. We love hearing your ideas. So we want to have another great conversation today. So next slide. Today's agenda, we're going to spend the first 30 minutes discussing the minimum criteria for the pre-hospital pediatric readiness recognition programs. We're going to do that by reviewing round 2 results. This is a continuation of the last session. And then hopefully prepare for round 3. We have about 11 criteria to get through today. The middle 20 minutes, we are going to hear from our communication team, and they're going to talk about effectively communicating your recognition programs. And then we'll follow up and close the session with discussing the emergency department minimum criteria and reviewing the round 3 results that everybody just completed last week. So with that, I think I will turn it over to Kasey and we can get started with our pre-hospital recognition program minimum criteria.
Thank you, Julie. Before we get too far into it, quick reminder, if you are looking for your state's responses to either the second round for pre-hospital criteria or the second and third round for ED criteria, please reach out to Eleni. You can chat her and she'll share with you the link to your state's responses. And then we can also put in the chat the link to the overall responses for the second round for pre-hospital and the second and third for ED criteria. That way you can see them a little bit more clearly and follow along as we discuss. So if you have any questions or looking for those, just go ahead and reach out to Eleni in the chat. So you might recall when we met last month, we discussed some proposed ranking, a way to think about the responses we were receiving. If we were having scores of 4.4 or higher, those might be the criteria that we're recommending as the minimum. And then that range of 3.01 to 4.3, stretch, and optional if anything was ranking below a 3. So we are following up with the pre-hospital second round. We ran out of time last month to finish them up. So we've already gone through a large percentage of these. We're just going to finish up those that were left. To orient everybody again, we have the criteria that's being proposed, the average score, which is one response from every state and territory that participated in the consensus activity, and then looking at those scores to see what the average maximum score was and the average minimum score. From those, we find the range, and that helps us identify consensus. The smaller the number is, the closer to consensus we are. Any questions concerning the table or help orienting to what we're looking at here? And this is what you'll be finding in the tab for pre-hospital round 2 in that document that Eleni shared in the chat. All right, we'll go ahead and get started with the first criteria for today, including pediatrics and policies and procedures regarding the care of unaccompanied minors. And so whenever we're looking at this screen, we have our average evidence score in the red, importance and feasibility across the top. And then in the dark blue is our overall average. So this one ranked 4.4 with a range of 2.3. So, great question, Emily. That was something we had proposed during the last meeting to get some feedback from the group of where we thought a good cutoff might be. And 4.4 was what we had heard from this group, as well as from the NPRP steering committee. But that's something we can definitely bring back up to the table for discussion if there's any additional thoughts on what might be a good cutoff.
Okay, I misunderstood. I thought 4.4 was proposed. Sorry. And then the group said, well, we're not sure how many are going to fit into that. So isn't it better to choose like the top X number rather than 4.4, which may be like an arbitrary cutoff point?
Yeah, and I think that's definitely something we can continue to evaluate. I think especially something to keep in mind as you're voting for the third round for the pre-hospital criteria. You know, if it's not something you want to see in that top recommended, we can vote it a little bit lower. And maybe we can reevaluate that in a better way when we look at the third round of results for the ED criteria.
Just one more comment about that. Typically, it's not just the overall score that we look at, but also the range, which I think Kasey is about to get into, because that suggests that there's consensus when the range is low. And it could also be that after this next round, there's, let's say, 5 criteria that all score, you know, a 5. And then there's a drop and the next one score 4.4 below. And then maybe based on that, the cutoff would change. So I do think it should be an ongoing discussion, as Kasey just said, Emily, and what you're also suggesting.
And I think a great example of that would be the pre-hospital personnel can locate pediatric specific equipment and include pediatrics in policies and procedures regarding the use of trauma triage destination protocols. They have a fairly high overall score, but the range is of a 4, meaning someone voted it a 1 and someone voted it a 5. So we're not quite a consensus. We have a wide range of thoughts on where that criteria should fall. What other questions do we have about the overall table we're looking at here, or how we might think about these moving forward? It's definitely the mean and our range are the 2 columns that we want to be paying attention to. So again, this is an opportunity to provide any edits to the proposed criteria, and those edits would then be considered in the third round. On the screen, we also have the comments that were provided during the second round for the pre-hospital criteria. So again, this one had quite a few pros, not many cons, but it looks like we might have some recommendations to how to phrase these. I think a lot of our criteria today are related to pediatric policies and procedures. So we left off. Anybody feels strongly about the inclusion of policies related to unaccompanied minors as minimum criteria, feel free to come off mute and this opposite direction. If anyone feels strongly that it shouldn't be considered as minimum criteria, definitely a great time to share with everybody. All right, we'll move on to that.
Can I just, sorry, Kasey, if I can just make a comment. I think There's two interpretations to the general comment of aren't unaccompanied minors by nature pediatric and this idea around informed consent. And the question would be, is this therefore not discriminating in terms of, pediatric readiness within the EMS system? Or is it so simple that it is by nature should be minimum criteria? So just some interpretations around that.
All right, I did want to bring this one back. We did discuss it briefly at the end of our last meeting. Sorry, Emily, I'm just seeing your message in the chat about this last one. I don't know if you want to come off mute and.
Yeah, sorry. I just didn't want to be the only one talking, but, yeah, I think just the wording could be simplified because unaccompanied minors to me means pediatrics. So instead of saying include pediatrics in that policy and procedure, just say has a policy and procedure for that.
Yeah, we can clean up the language there. All right. We will make that update and that's how it'll be presented then for the third round. So wanted to bring back a designated PEC because there was some recommendations last time to have a designated PEC who might support one or more agencies. I know we had to end that discussion a little abruptly, and I wanted to make sure that we were comfortable with making that change to supporting one or more agencies for the third round. I recall Dwayne had some comments in the chat at the end of our time on the topic too, so.
It's me, and it just seems kind of redundant to say that the designated PEC is a designated PEC no matter what, whether it's at one agency or at 15, I don't know.
Great. What other thoughts does the group have on the criteria of PEC for pre-hospital agencies? And if we're comfortable with you may support one or more agencies. That was really the piece of the conversation I wanted to follow back up on. All right, hearing none. Next criteria is established process for the regular verification of pediatric equipment and supplies. Not a lot of feedback on this one. If there was a request to define regular verification. If this was to be criteria, how might you define verification, regular verification? And feel free to just come off mute and share your thoughts on it.
I think the criteria is written as overly vague. Established process for regular verification, that could be a truck check. Or it could be a yearly inventory. I think it's overly vague.
Thank you.
So the proposal would be to either say a daily equipment check or start of shift versus an annual verification that's often done with the state. What would be your recommendation, Carrie?
I wouldn't recommend a daily check. We have volunteer services that they're lucky to do weekly checks. I think if we're gonna I think maybe a wording of regularly scheduled. That way it lets the service figure out what's most appropriate for them.
I would agree with that. There's a lot of monthly checks, especially when you get into medications where they look at expiration dates and other checks that aren't necessary to be done on a daily or per shift basis. And I think we can leave that term regular in there to let the state's programs define that a little better, or let the agency incorporate it into their current practices.
And Dwayne, did I hear medication should be included in there too? So equipment, medications, and supplies?
Well, no, some agencies have routines where they do a monthly or some sort of regular, and that's why I use that term regular, check on medications for upcoming expirations so that they know something is coming off at the end of the month, or they might move something into a more first line use if it's got a upcoming expiration date, so it doesn't go to waste and expire, or things like that. So it's just part of a process that might already be established, that the term regular becomes agency dependent, is what was said prior to that, and let the agency incorporate it into current practices.
Thanks.
I was going to suggest maybe the language that should be included is no less frequently than X. You know, we know that skills checks for verification of competency, you know, we say no fewer less frequent than once every 6 months, perhaps just the minimum suggestion.
And then I see a question from the chat, also verification of what equipment? What might be appropriate here?
I think the intent was whatever equipment that they've stated they carry and report to the state as carrying. So I don't know if others agree, but having the agency define that without trying to get overly granular.
There's only one level of granularity that I would suggest here, and that's verifying that all masks for the BVM are fully inflated. I can't tell you the number of agencies I've visited this year who are insistent that they have all the pediatric equipment. And when you ask them to pull out the masks, then they open the bags and they find they're deflated. And they said, oh no, we have the BVM, we see the masks are in there. And so that might be just one area where you want to have that level of granularity, is especially in Colorado and states where you deal with altitude, going up and down deflates those masks. And so, you know, verifying that the masks are fully inflated, or use it as an example of what you're going to verify.
Well, there's a lot in chat, so I want to make sure I didn't miss anything.
I can appreciate Nicolina's recommendation, but I think it needs to be left at the state level to determine. We can't, I mean, as an EMSC program manager, we can't be telling them what they need to do as far as their verification exactly. It's going to vary. So if that's something that one person wants to do in their state, that's fine, but we have to be really careful about how specific it is.
Would a compromise be to have a scheduled process that ensures equipment is in working order and is not expired? I mean, would that be an rather than specifying a specific thing, you know, have it focused on the outcome.
Great recommendation. What are the group's thoughts on that?
I do think it's important to remember that at least in some of our states, state regulations dictate some of these things, and we don't want our dictation to be in conflict with that. So I would agree that perhaps less definition is more here.
It seemed like we were a lot of agreement with the term regularly scheduled. So would that be the edit we would like to make to this criteria, or am I missing a key part?
Sounds like for the purposes of minimum criteria that's agreed upon by everyone here is regularly scheduled and to be defined further by each state based on what their expectation would be.
Some thumbs up. So our next criteria include pediatrics and policies and procedures regarding refusals. And this is involving children. We have the stem of the policy statement and then the specific policy, so we can work on the verbiage of that. But generally, policies and procedures around refusals for children. Had a couple comments. Might be covered under state level legislation. It falls under individual company policy. Any recommendations or changes to this criteria? It did have an overall average score of 4.3 and a range of 2.3. So it falls just below sort of that point we had discussed. Agreed, the pediatric and then children. Yes, we can update that.
I mean, most agencies have policies that cover all patients. It's not specific to peds. So, and again, it's up to the agencies to develop those policies. At least in the state of Oregon, we don't mandate any specific policies.
Any other comments on this one? We have policies and procedures. Policies, procedures, and training integrates elements of patient and family-centered care. So I had an average score of 4.3 and a score of a range of 2.3. For the same types of comments we received for the previous policy. What are the group's thoughts on having policies related to patient and family-centered care at the minimum recommended criteria?
Can I ask a clarifying question? How are we defining family, centered care in the pre-hospital arena? Because I know how it's defined in the healthcare in the hospital. But how are we defining it in pre-hospital?
It's really similar, actually, Pat, and it's included in the technical report, some discussion around family-centered care, but it ranges from, you know, communicating with families regarding consent for treatment procedures, integrating them into the resuscitations like we would in a resuscitation bay, but at least, you know, communicating with them, bereavement services, how do you speak to the family around the death of their child? So it's all of those components that would at least engage the family in the care and treatment plan.
Yeah, I think that I think those things are important, but we know from experience and that those things are very challenging to accomplish in the pre-hospital arena. You know, so I'm just wondering how our providers, our EMS providers, would respond to this expectation.
I think the expectation is in the form of a policy. The degree of adoption of that policy is not something that is easily measured, but it would suggest that at least the agency is committed to family-centered care, and that's really how it's kind of listed in the technical report or outlined in the technical report. So it wouldn't be like going through chart reviews necessarily, but at least having some suggestions around the importance of engaging families in the care of child. It could be very simple and just say that, or it could be much more complex and involved.
So this is one of those ones that I personally feel on the industry's going this direction away from policy and protocols and towards guidelines, that we're going to write a guideline as a template for agencies to adopt. Now, whether they make that a policy is up to them, but it gives them language and outlines direction to support what the technical report has in it to the degree that they can.
And in my experience with the EMS, you know, as an EMS director, is that, you know, a lot of this is the purview and of the medical director. So in terms of policy and procedure. So, I mean, the ultimate, you know, they are critical. It's not just the agency administratively that, I mean, there are some policies and procedures that are administrative, you know, as part of, you know, the workforce and that kind of thing. But in terms of patient care, you know, it's the medical director that typically drives the show in collaboration with the agency and the community.
So a lot to consider as you go into the third round of voting. Our next criteria was all recommended equipment and supplies are readily available. This one had an average score of 4.3 and a range of 2.7. We had some questions about wanting to define readily available and what that might look like. Anyone have?
I'm going to speak up on this one because there's scope limitations. And so our program is going to have that language in there. If it's a QRS unit, it's only required to be at the EMR level. There are scope limitations that they can't utilize some of the equipment, therefore they are not supposed to be carrying it, and therefore they can't, and they won't be able to meet that requirement unless it has that caveat.
Any other thoughts on that?
I concur with Dwayne.
Thank you. The next criteria was participating in a disaster drill that includes children. This one had an average score of 4.2, had a larger range, a range of 3.3. Quite a few comments on this one. It could be more difficult for rural areas. Any questions or concerns about the inclusion of disaster drills as minimum criteria?
I mean, it's a great opportunity. I don't think anyone would disagree with that, but it is challenging. I mean, right now we're trying to do just some basic simulations of a 2-patient 911 call, from the time of the call all the way through to the hospital. And we can't get our rural agencies to participate because they only have 1 or 2 rigs and they have to be in service, and it's just a whole thing. And so it's a nice idea and it is ideal, but I don't think we can ask them to do that. It's just not reasonable.
I think, a middle ground might be, possibly some, to participate in jurisdictional disaster drills, that include children, something in terms of not conducting them, not carrying the water to conduct it, but just, participating in, I mean, we have regional state plans, that type of thing. I mean, I don't know, I'm just thinking of the small agencies and the rural agencies that were mentioned. It makes it, pretty much impossible for them to achieve anything here unless just even pulling staff off to participate in any education is a challenge.
Great point, Emily. Virtual tabletop doesn't have to be a full-scale in-person drill. Things to consider. Go ahead and move on to the next one. Thank you for a great discussion. So the next criteria is has a pre-hospital disaster triage algorithm that includes children. This one had an average score of 4.2 and a range of 3.3. So we're getting to the point where our averages are lower and our ranges are larger. So less agreement on them being important and less consensus. That's some.
So this goes back to the EMS agency typically doesn't have a disaster plan. They're part of a larger regional or broader geographical plan, and that plan should have that component, but the specific agency level doesn't incorporate a component of a disaster plan that they don't develop. It's being developed and overseen by a higher level agency.
As I read this, we're just talking about a disaster triage algorithm. Does this just mean that the pre-hospital agency would kind of endorse or say they're going to utilize like the Jumpstart algorithm? That seems like a pretty low bar. That wouldn't put a lot of onus on an agency.
I think that was the intention. Yeah.
Okay.
I think if that's the intent, I would relabel it from disaster to mass casualty, because it doesn't have to be a disaster to be a mass casualty, which is when they use triage the most.
So a pediatric or a triage algorithm for mass casualty events that includes children.
That's good.
And then I agree on the renaming it, but I don't know if I use casualty and the fact is that you could have multiple pediatric patients that need to be triaged out of the casualty group, but still have to be managed as part of care of the disaster. So I'm not sure the language is all there, but we have to be careful how we name it so somebody doesn't get in the weeds too much with it. But I agree, it's not a disaster. It's multiple patients, multiple pediatric patients versus a mass casualty injury related type of event.
Yeah, even if you just said field triage algorithm, like keep it simple, and then they can decide which one they're going to use. And again, some states have their own field triage, like Oregon's just updating to the new ACS field triage. Then they're expecting agencies to use that for their triage of patients. So yeah, I think you have to be kind of careful about it for the same reasons we talked about with other things.
Thank you all for your input. So next we have a QI plan that includes pediatric considerations. This one had an average score of 4.1, but a large range of a 4. So we had folks who voted it at a 1 and those who voted it at a 5. A lot of feedback about it being vague, feasibility concerns. Any thoughts or recommendations regarding this criteria?
Again, this falls under the EMS medical director. In Oregon, there's specific rules that apply to EMS medical directors and what they're expected to do. This is not something that we could influence.
Yeah, by by regulation, there are things that mention what the EMS medical director is required to do, and any recognition program can't interfere with that. But I agree that QI should be, as directed by the EMS medical director, something like that. But I think vague is good here because anything is better than nothing when most are doing nothing, and then any other level of recognition might be more specific, where agencies are more capable of the more in-depth quality improvement programs.
The NIMSIS Peds dashboards will also more or less automate this for every agency. So worst case scenario, they will be able to have access to that if they participate in NIMSIS.
And Kate, I agree with that. And speaking of a state, it's just getting biospatial and just getting access to a lot more data. Before that contract with biospatial, those dashboards and that data was very difficult to access at the larger level, let alone the agency level. And I don't know of other states and where they are with it. So it might be a factor there if they're not engaged with someone like biospatial who is helping manage that data and form it out of what the NEMSIS dashboards create as far as data goes.
But I'll have to chat offline with you about the complexities of that, because I thought it was all being centralized through NIMSIS at Utah, but that's interesting.
In my experience with data systems looking for QI stuff, there's a lot of washing of the data that needs to take place, because in order to do a decent quality program. And so depending on the platform, and you may not be able to the platform matters in terms of supporting the quality of the data that is being sent to NEMSIS.
We'll move on to the next one. Utilizing a national consensus recommendations to guide availability of equipment and supplies to treat all ages. This one again had a score of 4 and a range of 3.7. So not our highest average score, but also not our largest range. So some standardized equipment, sort of competing against several states with state policies regarding equipment. Anything to share with the group regarding this criteria? Considerations for the third round. All right, well, in the interest of time, we'll go ahead and move on to the next one. This is our last one. Has a mass transport policy or protocol that includes children. This one has an average score of 3.8 and a range of 4. And lots of feedback considering mass transport. Anything you would like to share with the group or considerations before re-ranking in the third round?
I think I'm gonna go back to the individual agencies. A lot of times, at least in my area, are swallowed up by regional protocols. And so they don't have their own, and a lot of services, it's not feasible to have their own policy or protocol when it comes to mass transport.
Okay. Thank you. Something to consider. Any other questions regarding any of the criteria we discussed today? All right. Well, that does bring us to the end of round 2. So thank you so much for your input and your contributions. We're excited to move on to the third round. We'll be ranking based on importance and feasibility. That's going to get sent out after today's meeting. I have a couple criteria. We'll make the edits as discussed today, and then I'll get it sent out. We'll be considering the average score per state. You can share it with your team, your key players, and then we'll take those into consideration and calculate the average for your state or territory. If you didn't use it last time, we'll still be providing that handout with the consensus process to help inform your team and your key players of what's going on. We would like to share and get some input regarding the due date for this round. Our next session is on the 18th of April. We would like to recommend the third round being submitted by the 12th of April. It does give you about 3 weeks to re-rank the criteria. Feel free to let us know if that's going to work. Thumbs up would be a good sign that that might work for you and your team. 1 thumbs up. Maybe a little bit tight. What about any other states?
I'm just responding to Patricia's or Pat's comment about EMS medical directors reviewing these. A number of state partnership programs are taking these surveys back to their state advisory committees or councils that often include EMS medical directors or representation. And I think Kasey has stated a number of times that you're welcome to do that, and she will compile the average across your state responses.
Yeah. With our next session being on April 18th, we would like to be able to review the third round of pre-hospital criteria during that session. I'm seeing a couple folks mentioning that it's going to be a tight turnaround. Any other input? Is it not feasible? We could stretch the deadline. I think the 12th is a Friday. We give you Monday and Tuesday of the next week. Would that be a little bit more time? Feel free to let us know if that might work. That'd be April 16th. And a couple more thumbs up. All right, well, if it's not going to work for your state, please email us and let me know and we can reevaluate, but right now we'll aim for April 16th. Again, appreciate all of your input. We're gonna have a brief intermission of our consensus activity and get to hear from Amy and Emily. And then we'll come back and get to review our round 3 results for the ED criteria. So I'll go ahead and hand it off to Amy and Emily.
Thank you, Kasey. So you'll be advancing slides for us?
Yes.
That would be great. Thank you. Good afternoon, everybody. I recognize and know a lot of you, but in case we haven't met, my name is Emily Lemiska, and I am Director of Communications for EMSC. My colleague Amy Myers and I are very excited to talk with you today about communications and Peds Ready recognition programs and serve as a little bit of an intermission to all of your hard consensus building work. Next slide, please. So we understand that you are all in very different places in terms of the status of your recognition programs. So what we're going to do is first talk just sort of generally about the importance of communications, as well as some of the challenges of marketing recognition programs, and of course, some ideas and strategies for mitigating those challenges. Next, Amy will engage you in an interactive activity so that we can pick your brains a little bit in terms of what has worked well for states who have more mature programs, and then also how we can best support you, whatever phase of development you're in, with new materials and updated materials. For those of you who have participated in the Facility Recognition Collaborative that was held several years ago, you might remember that out of that came some marketing resources like talking points and a slide deck. So our comms and state partnership teams are interested in reviewing those materials and updating them and creating some new materials to help you. So next slide, please. Before we dive in fully, I wanted to sort of level set about, why should we care about communications when it comes to Peds Ready recognition programs? And the reason is that in a lot of ways, maybe a biased opinion, but recognition programs are sort of a marketing solution for the pediatric readiness problem. Recognition programs are vital because they verify assessment results, but they also work really well because they hinge on a couple different marketing principles and strategies. So the first is that they create positive reinforcement. That is probably really obvious, but it's also really important. Because recognition programs take a sensitive and kind of difficult topic, pediatric readiness, and they turn it on its head. They make clinicians excited and proud about their achievements in pediatric readiness. And positive reinforcement also works doubly because when it's exciting news, EMS agencies and hospitals themselves want to participate in marketing. So in a given week, I probably see that about 50% of EMSC's media mentions nationwide are actually stories about state recognition programs. And I can often tell that these media stories were put out by the agencies and the EDs themselves. So by hinging on positive reinforcement, we can really accelerate marketing for the entire program because we're actually engaging our target audience in doing some of our marketing for us. Of course, there are some risks with that, but it's largely a positive thing. The second thing is that recognition programs create what's called problem awareness. So often, and one of the biggest challenges of all of our jobs, is that people just simply don't know that the work we're doing is an issue in the first place. And this is especially true when it comes to the public, but can also be true of state officials, of health administrators, and sometimes even emergency clinicians themselves. So what recognition programs do, in a very gentle and subtle way, is that they call attention to the fact that pediatric readiness is something worth aspiring to. Next slide, please. So the way I'm describing it, you would almost think that these programs can just communicate themselves, but a lot of effort goes into marketing them, as I'm sure states with more mature programs know, especially at the outset of development. And there are a few challenges that occur when it comes to communicating about them, and I just want to talk about those. So number one is that these programs are really complex, sort of inherently. Within each state, we have varying definitions of levels of readiness and what readiness means. We have different tiers, we have different frameworks. They might be voluntary, they might not be. Those nuances are pretty challenging to keep track of, even just within a state. But they're especially challenging to understand at the national level. And so we see that confusion reflected when someone tries to look at recognition programs across the board, like with the Wall Street Journal article from this fall. There was a lot that they got wrong, but honestly, it's really complicated to understand. It's especially complex to understand and communicate the relationship between the assessment and then these state programs, and then, of course, other recognition and verification programs like trauma center verification or the new ED accreditation program from the American College of Emergency Physicians. So trying to help clinicians and the public understand how the recognition program piece fits into the Peds Ready puzzle can be tough. The second challenge here is that we're communicating about a really sensitive issue. So this is true of all of pediatric readiness, not just recognition programs, but we're trying to strike what's really a very fine balance. With clinicians, we're messaging that this is important and urgent, but we don't want to cause alienation or make them feel disempowered. With families, it's almost even harder. We want to message the importance and engage them in the conversation, but we also don't want to create panic or alarm or distrust of our emergency care system. We don't want to end up with families who feel like they can't go to their local ED when their child has a fever. But we also don't want either of these audiences to be apathetic or unaware of this as a very real issue and problem. The third challenge here, if those two weren't hard enough, we're also in a really niche space. So we are in healthcare, but then we're in emergency care specifically. And then we're even one layer deep from that because we're pediatric emergency care. So when you consider us against all of the other incredible number of priorities in healthcare today that are facing clinicians and health systems, it's no wonder that it's really hard for us to break through all of that noise. Next slide, please. Of course, we're not going to just talk about problems and not talk about solutions, and we're going to try to focus on some of these solutions today. We'll go through these pretty quickly and primarily just want to kind of get your wheels turning before we get into that interactive portion with Amy. So if problem one is complexity, then strategy one has to be consistency. We can't necessarily change some of the complexities of the topic at hand, but we certainly can ensure that we're not making it worse. The consensus process that you guys are going through now is obviously really important, especially because it will help us the next time that there is national level attention on EMSC. But even within your states, making sure that you have consistent messaging and visuals is really vital. I would encourage you to consider developing some key messaging, which are really just talking points that serve as sort of an internal reference when you're developing all other marketing materials. They will help ensure that your materials aren't like a bad game of telephone, where each new communication gets a little bit further away from the point. They're also really helpful because once you have key messaging, your other materials, whether it's a web page, social media, press releases, can become much easier to create and can almost kind of write themselves. A national key messaging template that you could sort of customize to your unique state's characteristic is something I'm hoping that we can come up with to help you, which we'll talk about more a little bit later. Consistency is also, of course, important in terms of visuals and branding. So when it comes to logos, there is just, logo soup in our world today. So I'd encourage you to think about how you can harness your existing logos and brand and create something that hinges on that rather than create something entirely new. And of course, a gentle plug here. If you haven't adopted the new EMSC logo, please no tomatoes here, but I hope you will consider it. I know that many of you have established brands within your states, and that is super important and is definitely a balance to strike, but we all benefit as a full program when we more clearly represent ourselves as one entity with many parts working together. And that can have that sort of snowball effect in terms of recognition and credibility nationwide. So quite simply, the strategy here is to always be thinking about how you can streamline and simplify your communications, because you'll just be more effective that way. And I wanted to give a shout out to Missouri in particular. They have done a really beautiful job of branding. I don't know if they're on today, but they've done a really wonderful job of branding their recognition program. Whenever I see them pop up in social media or in media alerts, I instantly know, like, oh, hey, that's Missouri's recognition program. So if you can do that, and if you can build that consistency, your audience is hopefully going to have that same response to your communications. Next slide, please. Problem 2 is the sensitivity of our topic. So how do we fix that? By having really balanced and really thoughtful messaging. So one way to do this is to try to target your messaging by audience, recognizing that in order to strike the right chord, your messaging to each group might need to be a little bit different. So an example of this is that your main webpage about your recognition program should probably be in terms that are pretty public friendly. But as someone clicks deeper into the webpage and the application process, you can imagine they're more likely to be a clinician, and you can begin to speak more to their specific needs and interests. I would also recommend that you lean heavily on stories. I know they're really hard to find, but if you can, they're wonderful. Stories are simply a very effective way to capture and keep attention. But they're also really helpful when you're communicating about a difficult topic. People can really get their hackles up if you just say, emergency care is bad. But if you tell them a story about Tommy and his family who had a really difficult experience at the ED, suddenly people are disarmed and they're more willing to listen, and they just don't feel as defensive. And I want to give a shout out to Wisconsin. I don't know if they're here. It's a long list of participants. But it was a few months ago, there was a news story I came across in media alerts, and it was really beautiful and hinged on a patient story. And it was just fantastic in terms of reeling people in and sort of instantly communicating what we're all about. Finally, here, we talked about the beauty of recognition programs is that they're creating positive reinforcement. So if you're struggling with how to message your program, you can always skew positive. But at the same time, I would ask you to make sure you're not too positive. So even though the piece was critical and had inaccuracies, I heard from quite a few of you that after the Wall Street Journal article came out, you got more interest in your work and your recognition program specifically. On the flip side, just 1 month later, a CBS Evening News segment aired that basically said, pediatric readiness is a problem, but it's not so bad. And I don't know about you guys, but I literally heard crickets after that piece. Like, it did nothing to move the needle. So I ask you to remember that a little bit of discomfort can cause change, especially in our 40th anniversary. We should all be thinking about how the EMSC program was funded and created because of a difficult story. It wasn't because a congressional staffer's daughter got really good care, it's because they got really bad care. So don't lose sight of the fact that we need to make people a little bit uncomfortable to create change. Don't be afraid to tell the truth just like it is, which is that pediatric readiness is making progress, but we still have a long way to go. Next slide, please. Finally, for problem 3, losing my words, 3, the strategy is to be as clear and as compelling as possible. What this means is focusing on what's in it for me. So that means, for example, when you're talking about recognition programs, make sure you're leading with the benefits and the impact. When you're talking to clinicians as a target audience, you should be trying to speak to what they can gain from pediatric readiness. So comfort, being more comfortable when they're dealing with cases, being more confident, and of course, the fact that they can save lives. I will also take literally every chance I get, if you know me, to use a presentation to talk about plain language, which is really just about communicating in as simple a manner as possible. This can be really challenging because we're in this niche space, but that's what makes it even more important. So often we're working really closely with like incredible clinical experts, but the reality is sometimes our experts are the worst ones at communicating things simply because they're so familiar with the topic and they're so well versed in it. They've forgotten what it's like to communicate with someone who doesn't know anything about it. So your role is to really be the translator for your target audience, who again, may be entirely problem unaware and have no idea what the heck you're talking about when you even say the term pediatric readiness. So just always try to be as straightforward as possible. There are a few tools that can help you with this, and I can drop those links into the chat. There's something called Hemingway app or HemingwayEditor.com, which is really useful. There's also a really cool readability and plain language analyzer tool that I love. And then, of course, everyone's infamous favorite, ChatGPT. Obviously, you always need to use it thoughtfully and very carefully. It's kind of like having a bad intern, but it can be really helpful to put something in that you've written and say, can you help me simplify this? And for this example, I would also just give a shout out for, you know, really clear messaging and branding, because that is what will help you break through the noise in your state and healthcare at large. And for a couple examples of states that are doing this really well, one, Evelyn in Illinois has a great website that's like really simply laid out in terms of messaging, recognition programs, and also Maine EMSC does a really nice job too. So I encourage you to check both of those out. Next slide, please. With that, I'm going to turn it over to Amy for our exercise.
Thanks so much, Emily. And hi, everyone. I'm Amy Myers, and I think I know most, if not all of you, but if you're not sure who I am, I work with Emily in KM and Communications for EIIC, and my specific focus is state partnerships and collaboratives. So this kind of like is like the perfect meeting of what I do here in this collaborative. But so today we're going to work on a quiz that I've put together. So Kasey, if you can go ahead a slide. If you all can go to this Menti survey, and if, hold on for 1 second, I'll put the link in the chat. Sorry. I was copying things for Emily to put those in, and I lost the link. Here you go, guys. So you can either do this on your phone or you can do it by opening a second window on your computer, but I'm going to share my screen so you can see it. Please let me know if you're having any issues getting in. Oh, great, you guys are already in. Okay, so first question. What strategies have you found? I have to move my bar, sorry guys. Are most effective in marketing recognition programs, and I'm going to ask you to select up to 2. And obviously clear branding, state partner collaborators, marketing, direct marketing to clinicians, media attention, social media, word of mouth, finding, sharing stories. Other is like in-person presentations. Maybe you did a booth somewhere. Maybe you sent emails out, or you may not be at the point where you're ready to be doing anything yet, and that's okay, and that's for not yet. I'm just gonna wait a second to see if we get anything else in there. Okay, great. So it looks like a lot of you have really started this already, which is awesome. It's nice to see, you know, a few pop up, state level partners, collaborators helping market. That is a great way to get other people to help you promote what you're doing every day. That's amazing. Finding and sharing stories, like Emily said, it's great. It's the perfect way to get someone to really listen to what you're trying to say by giving them a personal attachment to it. It's not just data, it's an actual personal story. And for those of you not yet marketing, don't worry, hang in there with us. We're going to get you there. Okay, so next question. What strategies have you found most challenging to implement? And now this will be interesting to see if they come out the same answers. Again, for other, it's things like, like I said, in-person presentations, having a booth someplace, direct emailing people, sending group emails out to listservs, media attention. That's a hard one. Getting the right stories out there. And social media, also a difficult one. And I can tell you it's one that we also go back and forth with a lot, even at EMSC, trying to figure out, should you be on Facebook? Should you be on Instagram? Should you be on Twitter? Should you be on LinkedIn? Do you need to be on everything? And if you're on everything, that's a full-time job in itself. So, I mean, finding the right places to be. Media attention and social media seem like they're the biggest, challenges. And you guys are dead on. All right, next question. What best describes your visual brand or logos for your recognition program? Are you not there yet? Do you have a recognition program without a logo? Do you have something that really looks like your state logo, or do you have something completely different from your state logo? And for those who have something completely different from their state logo, I would love for you to unmute and tell us what you guys have. What you're using. If you're feeling brave enough to share.
I just emphasize there's no wrong answers here too.
Oh,
Like
can you hear me?
I can hear you. Everyone else
Oh,
hear
I
me?
can't hear you guys. What happened here? Let me take these out and see what happened.
I was just gonna say while Amy's getting her tech fixed, that there's no wrong answers. This is all just to help us better help you and kind of understand, where you're at, what's working.
All right, can you guys hear me?
Yes, can you hear us?
I can't hear Emily. Okay.
Okay.
What happened?
New England has the New England Regional Always Ready for Children program logo we use.
Got it. I figured the ARC programs might be a lot of the folks that don't have a logo that aligns with something else. Okay. Poor Amy's having tech issues. I feel like that's been happening to a lot of folks this week. Just one of those weeks. Okay. So I think we're good to move on. So thank you guys for input on the visuals. So last one here, what points, if any, do you find challenging to communicate effectively and simply? And so this one is kind of about, thinking about key messaging and definitions and things that we want to help kind of figure out how to word for you and how to help you communicate them effectively, and trying to understand, like, what are the sticky wickets and messaging for you all. So there's definition of pediatric readiness, definition of recognition programs, tiers, importance to clinicians, importance to the public, the relationship we talked about between the assessments and the projects and the programs themselves, the role of your collaborators, role of HRSA. Super interesting to see this coming in. So a few around, just quite simply, like, what is pediatric readiness and what are recognition programs? But the most common concern is around how to get this across to clinicians. So that's really good for us to know, because we can kind of try to target working on that for you. And then the relationship between the projects and assessments, also interesting. Amy, Amy, you're back. Do you want to take over? Yeah.
I am. I'm so sorry, guys. I don't know what happened there. I think my AirPods died or something. All right, so yes, exactly like Emily said, you know, the importance to clinicians, so that's great to like let us know that's where we should focus, and also the relationship between recognition program and the Peds Ready projects, so important. Okay, great. So I'm gonna move on to the next slide. So select up to 4 types of materials or templates that might be most helpful to you. Talking points, elevator pitch, press release, flyers and brochures, slide deck, web page, newsletter, social media, on and on. This is mostly for you guys. Like what would be most helpful from us for you? Like those promo packages we make and send out to you when certain things are going on. What would you like to see in there that would help? You know, starting points that you could just customize. And you could select up to 4, so. This is great, guys. Thank you. I'm just gonna give you another second just to. I love the talking points. For whoever put other, maybe you can share if you want to share out loud, or if you want to share in the chat what you meant by other, we'd love to know. Because you may be thinking of something that we forgot. Or more infographics.
Guilty. Yeah, I use the one infographic that has like the impact of readiness on the critical care, medical, the trauma. And I lean heavily on that one. I'd love to see more infographics in that vein that translate that there is evidence why we're doing this.
Oh, that's great. Thank you. All right. Good information. All right, but I see that it's slowing down now a bit. So it looks like talking points would be the most helpful. I get that, and we can work towards helping you put something together, or at least giving you starting points that you can then work to fit into the plan you're developing for your readiness project. Flyers and brochures, we absolutely can give you some templates for that, and a slide deck and all this. This is great. So Emily and I will take this back and we will work on this together to try to, you know, bring you what you all need. If there's something else that you think of after this, like the infographics that we forgot to highlight, please feel free to reach out and tell us. We would love to hear from you to try to help. And I'm going to turn it back over to Kasey, and which should be our thank you slide. So I will say thank you for your time. Sorry for the communication problem in the middle of it. You never know when that's going to happen. If you have any questions and if you need any help, that's our email address. Emily, did I forget anything?
No, just that this was super helpful information for us. We obviously have a lot of homework to do. So you helping us know what materials are most useful will help us kind of prioritize and, you know, sort of stagger the rollout of those. Jennifer, really appreciated hearing about the outcomes infographic being useful, because I think it's almost even another case of consistent messaging, where so often we've said, you know, 4-fold decrease in illness, but now we have new data, and 4-fold is also kind of hard to understand for a you know, lay audience. So we're trying to shift people to, you know, 76% lower mortality, and also talking about that 1,400 lives saved number. But anyway, yes, thank you so much. And we can also share the results of that first question with you all, because for those states that have new and developing programs, I imagine it might be helpful to see what other states have said has been most impactful in terms of communications. So thank you all so much.
Yes, thank you.
Thank you so much, Emily and Amy. Our very nice intermission. Appreciate it. Great to get a better insight about what our recognition programs are doing. So that brings us to our ED recognition recommended minimum criteria. We've completed the 3rd round. So thank you everyone for getting those results in. Similar to what we discussed at the start of our pre-hospital criteria, we were considering this proposed ranking of 4.4 or higher becoming the recommended minimum criteria. So again, if you've not seen your state's results or the overall results, message Eleni and she'll help you get to those links. But especially this screen that is on the tab, it's round 2 and round 3 for ED criteria. We'll get to see what we changed from round 2 to round 3. There was a couple changes in the verbiage for the criteria, and then you can also see where the criteria landed. So this is not fantastic for your presentation view, so I recommend looking at it in that Google Sheets. But we can look at just the results for the 3rd round. And again, I've highlighted those that had a score of 4.4 or higher. And that includes access to pediatric emergency equipment. And we discussed last time that being crash cart or bag in the emergency department, at least 1 PEC, weighing children's in kilograms only. All recommended equipment and supplies are readily available within the ED. Weighing and recording children in kilograms only, and including pediatrics and policies and procedures. The last one was disaster plan must include pediatric considerations. So based on all the results we received, those are the ones that had an average score of 4.4 or higher. And then similarly, you can see our minimum score, our maximum scores, and we're looking at that range. So those 2 items we want to maybe consider would be what is the value of the average or the mean, and is our range low, indicating that we came to consensus. So one of these that I want to draw your attention to quickly is the weighing children in kilograms only. It does have a minimum score of a 1 and a maximum score of a 5, resulting in our range of 4. But it does have a high average. And I can share that the score of the 1 did indicate they felt that the criteria weighing and recording children in kilograms only was a more important criteria, so they weighted that one lower. So that is something to be considered. We have, 2 similar criteria that ended up in this top range. So what might that mean for our discussion and considerations moving forward to making a recommendation? So having just seen, the average results for all of the criteria we discussed, what is the group's thoughts on what we're seeing here? Did our top criteria land where you thought it might, or were there any surprises? Are these criteria that we would be happy to see as recommended minimum criteria? Weighing and recording is more important than just weighing in kilograms. We definitely did see that come out, and we're move past. We start with the weighing in kilograms. We can start here. So we see that this one did have a range of 4. Overall average was 4.5, feasibility was 4.3, importance of a 4.6. And we did receive 44 states and territories that responded to this round. And then we can also reference back to round 2, the overall average was a 4.7. So we did have a little bit of a decrease in the overall average from round 2 to round 3. But again, this is the criteria weighing children in kilograms only, not considering weighing and reporting. And then if we look at weighing and recording in kilograms, average, overall average 4.4, feasibility of 4.2, importance of 4.7. average importance for round 2 and round 3 were the same at 4.7. This one did have a smaller range than just weighing, so we're closer to consensus when we're considering weighing and recording, but there was a lot of feedback about what the implications might be related to issues related to EMR and how that might impact a site's ability to be successful at this criteria.
Just a comment on this one. I mean, I think everybody agrees how important weighing and recording in kilos is for patient safety and correct medication dosing and treatment. One of just looking at some of the comments around this, you know, if an EMR automatically converted a weight into both pounds and kilos, then the intent of this is that that would not be acceptable. And so some of the comments that I think people have made is that adaptation or modifications to an EMR within the locus of control. And, you know, I feel, I'll just personally say that I feel, you know, almost ambivalent about this because I know how important it is. And I also recognize the challenges of making EMR modifications. But I do think that the benefit of a state saying this is required is it starts to really push a culture change. The disadvantage is that you may not have as many sites that are successful in being recognized as if this is a requirement. So that's kind of the plus minus that I just wanted to share.
What are some other thoughts from the group regarding weighing and recording versus just weighing in kilograms? Looking to the importance of it.
I'll jump in. This is Kelly from Illinois. For me, like there is no standard of practice in my mind outside of weighing and recording only in kilograms. There's just too much room for error to weigh in pounds, and then the conversions, even if the computer's doing it, just personal experience having been at a facility that had a medication error due to somebody weighed in pounds and then allowed the computer to, you know, doing the converting. But they ended up putting in later on in the document the pounds instead of the kilograms, if that makes sense, later on. And also then once our documentation was only allowed to accept kilogram recording, somebody inputted the pounds because they were converting it for the family, and that was the last number they said and had in their mind. We've got to move away from allowing pounds in our verbiage at all related to weight.
Thank you, Kelly.
This is Morgan. This seems like it's an issue that's been well documented for so many years. We all agree it's of critical importance. I would love to see some work at the national level to convince the major EMR companies to make this the default. Instead of all of my hospitals having to work to try and make this change, if we could get the companies to present this as the default and the hospital would have to work to change it to where it did show both, it seems like we'd be much closer to our goal.
Thank you, Morgan. And some other comments in the chat too. Nicolina, what is the criteria related to kilograms for your recognition program?
We require all hospitals to weigh and record their patient weights in kilograms, and we specify pediatrics. But what we've really been advocating is weigh all patients in kilograms and record it as such. And we've seen some really creative hospital-driven solutions where where the scales are posted. They have conversion posters from kilograms to pounds because patients always ask, but it's not pounds to kilograms. We have also seen one facility who was waiting to purchase a new scale because they didn't have it in their budget. And it was an infant scale and it had a pounds and kilograms button. And they put a sticker over the pounds button and it says, "Here we weigh our patients in kilograms," which I thought was remarkable because it was about changing the culture of how we talk about patients. It was very positive. We've also had really great success with one of our hospitals' IT department working with their specific EMR to adjust the field so that you could only record in kilograms. It wasn't a conversion. And so we've just seen some really cool stuff with facilities leading the charge and educating their patients as well. But lots of positive messaging. Another facility had a sign near their infant scale that says, "If I'm under 2, please remove my clothes so you can get an accurate weight in kilograms." And so they just keep positively reinforcing kilograms, and it has taken some time, but they're getting there, and everyone has been able to facilitate this.
To hear. Thank you for sharing. Well, we are quickly running out of time. So want to be aware of that. We're going to go ahead and continue this discussion next month. So you have your state's results and you have the overall results. Feel free to review those, and then we'll continue to discuss those top criteria for the ED minimum criteria next month. And then you will be receiving the pre-hospital minimum criteria consensus activity for the 3rd round after today's session. And then we'll come back together on the 18th. And then I think we ended on April 16th as the deadline to submit your responses to the 3rd round. But before we go, we did want to get your input on some future topics. So I'm gonna go ahead and launch a poll. Please just take a moment to share with us which of these topics you might be interested in hearing about during future sessions. There's also a place to type in any other ideas you might have that you would like to hear about. So again, appreciate all of your time today and working with your teams to get their input collected for the criteria activity. So really appreciate that. And then we'll use your responses here to help guide some future sessions. And as you finish up that survey, we will see you next month. Thank you.